Welcome to the Alain Elkann interviews, an unprecedented window into the minds of some of the most well-known and respected figures of the last 25 years.
Virgilio Sacchini, where are you, Professor? You are working at the Sloan Kettering Hospital in New York?
Yes, I'm a professor of surgery at Sloan Kettering Cancer Center in New York and professor of surgery at the University of Milan in Italy.
And you also teach in Zurich, right?
Yes, but mainly the academic function is mainly in New York and in Milan.
Is there a lot of difference nowadays between Italy, Switzerland, United States in the studies, in the quality of the doctors?
I would say that the quality of the doctors is very good everywhere. There is a sort of a globalization of the medicine. It means that the protocols are now international, online. New medications are available around the world. So I think that the standard of care now is similar, at least for cancer in all the world. Now with the web conferences, I think there is more access to information. It's possible to follow these several cancer conferences around the world, and it's possible to have real-time information. It's possible to discuss with the different investigators. I think there is a sort of a better access now to information.
You are an oncologist and you're specialized in women's breast cancer. I know you started in Milano, you started working close to Dr. Veronesi, and then you were called in America and so on and so forth. But is there a lot of progress in your specific field?
There are a lot of progress in cancer in general. The screening, the diagnosis is more and more for earlier cancers, and the treatments are better and better. Better screening, better identification of high-risk patients.
How many of these women die and how many survive? What is the percentage?
The probability of curability for cancer, breast cancer, is better and better. It depends on the stage, it depends on the type of cancers. But usually we say that the probability to be alive for a woman with breast cancer in 5 years is now about 90%. That is quite a good percentage. 98% of the patient has a stage 1 breast cancer. So the early diagnosis is still very important.
Early diagnosis is because after a certain age, you want women to do a checkup, right? They have to do it regularly.
Mammography was very important in detecting early cancers, improving the survival, and usually the mammography started when the woman has 40 years, more than 40 every year, and until 70, 75. And this can really increase the early diagnosis and the survival of the patients. Unfortunately, in these COVID moments, we are seeing an incredible drop of the screening for all the cancers. For mammography, for breast cancer screening, the screening dropped by 85%.
You talk about the United States or also in Italy?
Europe and the United States is more or less the same. The drop in the screening for breast, colorectal, lung is quite impressive. 85% for colon cancer with the colonoscopy and for breast cancer with the mammography. And this is of a very, very concern because it means that we would diagnose later stage cancers.
In other words, you think that because of coronavirus, patients who are afflicted by cancer or even by heart problems have been neglected, right? And so there has been probably an increase of deaths in this kind of illnesses, including diabetes or other things.
Absolutely, yes, for two reasons, because the health system is concentrated now for treating the COVID patients. That is an important emergency. So there are less resources for other diseases. Plus, of course, patients don't want to go to the hospitals because they are quite afraid to get the coronavirus. We are diagnosing now less cancers, absolutely less cancers, 40% less cutaneous melanoma, for instance, the skin cancers.
But your hospital, the American hospital, the Sloan Kettering, which is specialized on oncology, during the coronavirus time, what happened in your hospital? You wanted to have corona patients, or how does it work?
During the highest pandemic peak, April, May, we only were able to operate urgent patients. So we delayed the treatment of not urgent cancers. It means that we prefer, instead of operating, to give treatments, to be able to wait for the surgery. Of course, cancer is always an urgent matter, because sooner is better. But we couldn't because all the resources were ready for COVID patients. So we had to delay treatments.
I'm sorry to say that the first phase of coronavirus was not treated with tremendous success in the United States, right? Now we are in the middle of a second wave of coronavirus. Did something change? I mean, is the healthcare system functioning better, or it's still the same?
I think is much more prepared in terms of identification of coronavirus carriers and better quarantine and isolated the coronavirus patients. We learn how to treat. So we treat better the coronavirus patients. So it's definitely better with, of course, less mortality. Why some areas had more mortality than others? Probably because the concentration of the population was much more, like in New York, in some areas of New York, Queens, Bronx, Brooklyn, where the density of the population is quite high. There are buildings in which they live thousands and thousands of people. And the same, for instance, in Lombardy, in Milan, where the density of the population is quite high. And of course, the virus is more contagious.
You said that we find a cure now. What is the cure that you give now to the patients who have coronavirus?
There are protocols that are a little different, but here in the United States, the protocol is quite uniform. They treat at the beginning with cortisone, anticoagulants, heparin, because the virus can give blood clots, antivirals. This is I would say, protocol for early stages. This protocol is often applied in patients at home instead of admitting the patients. So treating at home probably was a good solution for some patients because they are better isolated. They don't require ventilators or heavy treatments. For instance, in Italy, there was this incredible fair, and the patients went to the emergencies, and there was a congestion of the emergencies, congestions of the hospitals. I think that patients, the most part, can be treated or monitored without going to the hospitals and overflow the hospitals. Of course, when a patient is at home, it's important to have the authorization of the oxygen. If the oxygen drops go to 90, 89, 88, it may be worrisome. And of course, the patient has to go to the hospital. So there is the monitorization is important, but it's important to have resources, monitoring these patients, calling this patient, be sure that the patient is self-monitoring. The way you may have some risk for the patient.
Biden administration, it's oncoming. You think that the previous administration, the Trump administration, has not given sufficient importance to this, and that under Biden things will be better? We talk about medicine and healthcare.
In general, we didn't see big difference in treating patients with the Trump administration with respect to the Obama administration. We were able to take care of poor patients with the Medicaid. We were able before to take care of the Medicare patients. We didn't see any restriction in, I would say, quality of the treatments. Probably there were less patients insured, and this was the problem. It means that with the Obama administration, there was probably an increase in the insured people with respect to the non-insured. But I don't think the difference is very important.
This attitude, not to wear the mask, to minimize the importance of COVID and so on, you think it was dangerous for the United States?
Of course. I think that the precaution measures are so important. We know the isolation is very, very important. The mask can really raise the spread of the virus. Of course, nothing is 100%, but can really help. The impression is that the virus would infect no matter. So the virus may infect all the population until we would have the vaccine. The problem is in how many time. It means how is the concentration of contamination over the time. So if the contamination is in a narrow time, in a narrow interval, of course, the health system may collapse because there are an incredible number of people who would require treatments. If the contamination is spread along the months, weeks, of course, we have less stress on the health system because you're going to have a lot of sick people at the same time. So there is a dilution of the patient.
You spoke about vaccine. Now we know more or less that they have found, or at least announced, 3 types of vaccines, 2 from America and 1 from the UK. They are not exactly the same kind of vaccine, but they all say that they have 90-95% chances to function. What is your opinion about this?
I think, of course, the vaccines can really work very well to have different actions, injecting some mRNA able to stimulate the body to produce antibodies against the protein who would allow the virus to enter the cells. The other one is the classical vaccination with a similar virus, but in a not so dangerous as the real virus. I think that the vaccine is the only way to protect, to stop the spread of this disease. And in my opinion, they are quite safe. There was an incredible effort to have the classical phase 1, 2, 3 studies able to declare, to see the vaccine to be safe and in time to be very effective. So I think that the vaccine can really be safe. Of course, all the vaccines may have side effects, sometimes very important side effects. And of course, we need to accept, because if you calculate the risk and benefit, the benefit is much more than the risk. I don't think this type of vaccination would have more side effects with respect to the conventional vaccinations that we do for the flu, for instance.
You don't know which one of the three will be adopted, right? Yet. We don't know when. And also there is another question is how long will it last? And then some people are obviously relieved and others are afraid because they say this has been found so quickly. Normally to make a vaccine, it takes more time, it takes a longer research. So there is optimism, but in the same time, a lot of questioning.
Absolutely. Probably here in the States, we would have the Pfizer and the Moderna vaccine. They're speaking about vaccination in a couple of weeks, 2-3 weeks, especially for the health workers. The vaccine wouldn't be mandatory, but at the end of the story, if you don't get the vaccine, you may have some restrictions, especially for us. You cannot be in contact with the public, so probably vaccinating will give you more confidence and liberty in doing things. Of course, the concern is possible side effects, but at the end of the story, I think that the only difference in approving this vaccine was the time. They did everything much more fast than in a conventional vaccine. First, because there was this emergency, and second, they had a lot of support for doing this, but they completed the phase 1, phase 2, phase 3 classical studies before the approval. Of course, you cannot exclude the possible increased risk of side effects, but looking at the studies, the side effects seems to be very acceptable.
On your sense, how long it will take before going back to normality? Before this pandemic, we were living with all the obviously illnesses, flu, cancer, but we didn't have this strange invisible enemy right over our heads, and we're not washing our hands every other minute, putting a mask, keeping distances, being frightened one of the other, and so on and so forth, right? So when do you think that all this will disappear completely, that we will be confident to kiss each other, to see each other, to go to the cinema, to do a really normal life without suspicion, without fear?
It's very difficult to tell. For me, a normal life would be normal screening, normal operations, normal treating my breast cancer patients. This is, of course, my priority. I cannot say would never have a normal life again, because this was a terrible experience and everyone would be afraid for years. But if we look at the history is so very important. Sometimes we forget the history. The Hispanic flu, after 2 years, everything was back to normal. I don't want to tell the plague in the medieval, but of course, if you look at the history, sooner or later, people would return to normal. The other problem is that we don't know enough about this virus. So we don't know. We know that the virus can change. We know that the virus at a certain time would disappear or would remain a little better in the population. But of course, it's very, very difficult to predict. Hope that in a couple of years, we should be completely back to normal.
Do you think that COVID-19 will be just, as you said, a terrible episodic like the Spanish influenza, or we will have to face a world with many other pandemics? And are we prepared for that?
This was an incredible learning lesson for us, for the humanity, of course. The humanity forgot the pandemics and forgot the plagues, forgot the Hispanic flu. So probably we will be much more prepared. The health system will be much more prepared for these possible diseases. And we cannot exclude that we may have in the future another virus, but probably we will be more prepared and the population will be more prepared. And of course, we learn a lot.
You as a doctor, right, as a professor of medicine, how did you face this period that now is lasting more or less since 1 year? How did you face it as a doctor?
First, we are concerned. We are concerned for ourselves because we are very exposed. Probably we are not exposed like the intensive care unit doctors, but of course we see and we treat COVID patients with cancer. So we are exposed. So we are concerned to get the coronavirus and to die. And I have colleagues who almost died for coronavirus. So this is the first consideration. So we need to be very protected. But in the meantime, we need to treat. We need to treat because we estimate that delaying the diagnosis would lead in an increased mortality for cancers in general by 10% in the next 5 years. It means that every year almost 10 million people in the world would die for breast cancer, and we may expect 11 millions in the next years due to this pandemic. So we need to treat. We need to treat. We need to tell the population that there are important diseases, not only the coronavirus, to prevent and to treat. So we need, as a specialist in cancer, in heart and neurologic disease, to continue. And of course, to tell people and patients that we are ready to treat and they don't need to be afraid to search for prevention and treatments for cancer.
What did you personally learn in this situation? Did you learn something for yourself?
Yes. I learned that life can be very unpredictable. And I was several times scared that I got the coronavirus. Not sleeping at night, palpitations, difficulty in breathing, and telling, well, I got the coronavirus probably from that patient. Now I may die for the coronavirus. And then, the next day doing the swab and the antibodies and discover that I'm clean without any virus. But of course, it's an incredible stress for not only the population, but for the health workers. And my colleagues the same. My colleagues, my nurses the same. Every 2 weeks, it's mandatory to do the swab just to try to maintain a COVID-free environment in our hospital. And it's a relief when it's negative. But we learned the fear of an invisible enemy that can really kill people.
In your hospital, you are very advanced in new technologies, DNA studies. Is there going to be a substantial progress for future illnesses because of that? I mean, are you advancing? We talked about breast cancer, but there are many other cancers. There are many other fatal illnesses. I mean, this advanced study of DNA and other technologies or scientific discoveries, are they making considerable progress?
Yes, of course, because we developed the concept of the precision medicine. Precision medicine, it means to better identify patients at a high risk for cancers and to screen patients, women, men, in a different way. So the DNA study is important to identify mutations. It's important probably in COVID too, because probably there are some men and women more predisposed to COVID due to some genetic differences that they are going to study. And then the treatment is different because we saw that cancers are very, very different from the DNA point of view. And we can identify the DNA abnormalities, the genomic alteration in the DNA of cancer cells and be able to treat in a different way with specific medications. So the DNA can really and is really improving not only the diagnosis, but only the treatment of cancer, and especially the precision in treatment, not blind treatments that may or may not work, but very precise treatments against the specific cancer cell.
Do you think that the restrictions, the lockdowns, remote studying, remote working is going to have a negative impact in the children, in the young people education? You think that this long year, maybe 2 years of exceptional life where everything is different, is going to impact psychologically and therefore the health, mental health, or physical health of the young generations?
Yes, and not only the young generation, but to everyone. Less you move, less you exercise, you are at increased risk of cancer, heart problems, probably mental problems. So, of course, the lockdown had and would have an impact on the physical and psychological well-being of people. And, of course, young generation, everyone experience collegiality, everyone experienced how nice was interfacing with co-workers. So I really think that the life of the relation is so important that we would have an important impact with the lockdown.
Do you think that it is very difficult to make decisions when you are on this double feature of economy and health? If you close, the economy will go badly, people will lose jobs. If you don't close, the pandemic will spread. You have seen how much they discussed about Thanksgiving, how much they will discuss about Christmas. Do we open? We don't open. In some places, they even forbid skiing. In other places, you have to go home by 9 o'clock. In other places, you can't move from one place to the other. I mean, all this is very special. And do you think that politicians all together in the Western world, because we don't know much about what's going on in China or in other countries, are they handling decently this situation?
I think this situation is so difficult, and I think they have an incredible difficult position. They try, of course, to decide between economy and health of the people. I would say life and death at a certain point. So I think they have a very, very difficult task. And the other problem is that this virus became a little political. It means virus from the right, virus from the left, virologists from the left, virologists from the right. And this is the bad thing that you can have, because science has to be based not on the political parties, but on the scientific evidence. But the problem is that we don't have enough scientific evidence from this virus. What I noticed is that the difference, for instance, between the United States and Italy. In the United States, there was quite one voice, the National Cancer Institute, the National Institute of Health, voiced by Fauci, and everyone was following his recommendation. He is a man of incredible experience. In Italy, there were many opinions by different virologists telling one thing one day, another thing another day, and sometimes the virologists were not very well qualified. There are, for instance, virologists who are veterinary. And of course, in animals, you have a different approach. They appear every day into the major networks. So what I don't think is right is to have several voices not coordinated by a central system, like the National Health System, Health Institute in the United States. So this is the problem. And of course, there is a task force, and I think that politicians should, at a certain point, listen to the task force, but the ministry should have also some experience in, I would say, better evaluate the final recommendations of the task force.
What will be the impact of artificial intelligence in the field of medicine?
I think a very important impact, and especially in the evaluation of big data. What does it mean? That now with these incredible systems, you can enter incredible big data, and then the artificial intelligence can look at the data and make some final diagnosis. For instance, if you have X-rays, you put the X-rays into the system, and it means that the system is able to analyze the single pixel of the X-ray. Then you, of course, give the system the diagnosis of that specific X-ray, and at the end of the story, analyzing millions, billions, trillions of pixels, the system can make the diagnosis by itself, giving, of course, the first correlation. So I think can really help. Or the other thing is the so-called Watson system. The Watson system is a system in which you put all the data of the patients that you treat for a specific disease in the last 10 years. You put the result of the clinical trials, you put everything, and in real time, when you enter the data of your new patient, the system is looking at what happened in all the 2,000 previous patients, can give you the diagnosis and can give you the treatment. Really help. Cannot substitute the physician. The physician has to be, because of course there is a margin of error. It's like when they pilot a plane, that of course you can have the automatic pilot and you can sleep and the plane will do everything alone. But if you have something different, not predictable, you need a pilot, you need a doctor who can pilot the treatment and the diagnosis.
You are a professor in, as you said, in New York, and a professor in Milano and sometimes in Switzerland. By looking at your students and the kind of students you have, do you think that doctors of tomorrow will be different from today's doctors?
Of course, they would be different because they would have more technology available. When I graduated, we didn't have the CT, for instance. And now you cannot practice without the CT. So they would have more technology available. They would need to be more and more familiar with the new technologies, and they may work better. They would be more precise in diagnosing and treating. I can see in the students a lot of enthusiasm. They are enthusiastic, and I'm very happy when
Enthusiastic in Milano, as in New York or in Zurich?
I think more or less is the same, because the globalization is something, in my opinion, very important in exchanging the information, and you can really have more or less the same quality from the teaching point of view, from the quality of the student point of view around the world. Of course, the difference is that in the European universities, we are more theoric. We study the theory more. In medicine, we study the anatomy much more than in the United States. So we have a very, very solid base. The United States, they study a little less the theory, but they are more practical. Right away into the hospital, right away in contact with the patients. And of course, this is better from the treatment of the patient point of view. But in the meantime, having more basic science to better understand.
During this time of closure, lockdown, pandemic, remote and all that, you can do everything, but you cannot operate. And you are also a surgeon yourself. Whatever research you have, whatever artificial intelligence, whatever DNA, at the end of the day, many times one has to operate, right?
No, of course, we continue to operate, of course.
And this has been Sloan because of one disease that you talked and you were sincere about that, is that there is a lot of fear, right?
Yes.
There's fear in the patients, there's fear in the nurses, there's fear in the doctors, because we are all humans after all, right?
Of course, but of course we need to take care of patients. And the problem is that we operate less because we have less patients because they don't do the screening. So in this months of pandemic, we have 35 less cancer patients. 35 less. Why? Because they are not diagnosed. Because they do the mammography, they are not diagnosed. Of course, 6 months from now, we would have 35% more because the patient will be diagnosed, unfortunately, with a later stage. So we work less, but we work. We work because we have patients and we need to operate. Unfortunately, we cannot do the smart work at home because we need to be in the operatory room to operate. But we have time, of course, more time because we have less patients to research, to look the last data, to study, to do our own research.
Even with the corona, the number one cause of death is always the heart, or at least the brain or heart attack.
Of course, the first is always heart, and unfortunately, corona can increase the risk of heart problems, blood clots, some stroke, of course. And the second is always cancer, the second cause of death. 10 million people die every year for cancer in general. And now we have 1 million, almost 400 people who die in the world for corona. It doesn't mean that we don't need to take care of the coronavirus. No, absolutely, we need to take care of the coronavirus, but we don't need to forget about the other patients, the other diseases that are very, very important. I mean, 1 million more cancer deaths every year from the coronavirus situation is too much.
Alain Elkann interviews.